It's for mild incontinence where you're not losing more than maybe not more than a cup of urine a day or a couple pads a day. If you've got heavy incontinence or complete uncontrollable incontinence, then you would be most likely informed by your urologist that you would need an actual implantable 3-piece urinary sphincter, which is an actual inflated cuff that is surgically placed around the bladder neck, and it has this little reservoir fluid, which is a little bubble that sits under the skin, and you can't see it. And in the scrotal sac, there's a little pump. So every time you want to go to the bathroom, you press the little pump in your scrotum. The reservoir fluid leaves the cuff, it goes to the reservoir, empties the urine, and then within 5 minutes that cuff reinflates with the reservoir that now goes to the cuff. Yes, that's called an AMS 800. If you wanted to know urinary sphincter, it's AMS 800. The slings we do either invance or advance, and that's the one that I believe that my mother's husband had too. So common procedure, you just have to kind of fight and ask for it. Topics that I discussed going on about the incontinence. So I go into detail, different patient situations, behavioral modification, including fluids, restricting fluids, timed voiding, meaning going to the bathroom, every so often so you don't have accidents. If you wait all day to urinate and your bladder's getting full of volume and more pressure, you're going to have accidents against one little sphincter that's trying to hold the load of that bladder. So when you cough, when you sneeze, when you move suddenly, I go into all of the things that stress incontinence implies and how to improve things. And then I go into Kegal exercises. I show patients penis clamps, how to clamp and use clamps. One of my favorite clamps I tell patients to use is a squeezer clip. So it's a daytime clamp, you can't wear it at night, but it's something that you just clamp on the base of the penis. And you release it every hour or so. And it's good for those guys that want to go golf or do something, not have to worry about changing pads or leaking every time they swing a golf club. But it is just something that contains it, so it's a container device. It's known to be a little uncomfortable until you get used to it, but it's squeezer clip, and it's clip with a K. And you can find that at squeezerclip.com. I then talk about biofeedback. Biofeedback is something that is done by a physical therapist that is a specialist in the pelvic floor. So there's electrical stimulation, there's different techniques that a specialist can do, such as a physical therapist, in showing a man on transducers on a TV screen if they're able to do a Kegal exercise correctly, or if they're using other muscles that are not even in the pelvic floor. So therapists can tell. I can tell a patient verbally how to do a Kegal exercise, but about 30% of the population, women and men, can't locate the muscle. And being able to locate the muscle is actually the first step. Perineal discomfort and bleeding, I tell them about the postoperative common things that are expected. A little bit of blood in the urine on occasion. After 8 weeks, I tell them if you see blood, it's either an infection, or you've got some scar tissue, or a contracture, or hopefully no other cancer going on in kidneys or elsewhere. So expect a little bleeding occasionally, but if after 2 months after treatment you still see ongoing bleeding, you should visit with your urologist. Now, if you've had radiation therapy, that might be an on-again, off-again thing that you see over your lifetime. And it depends on what kind of procedure you've had done. Erectile function with an emphasis on rehab initially, and then I focus on sexual function. So what I try to do is the majority of this whole class, as you'll see on my next slides, the majority is helping patients understand how to use products to help get blood flow into the penis. Okay, so I go into all of the pills, the pumps, and everything else. So that's the focus. And then I have a little talk, that last point, the importance of communication with partner and or the involvement of support groups if necessary. I do spend a good amount of time with the patients telling them men have a #1 fear after this type of treatment of performance failure. Can you imagine after treatment, you're thinking, how am I going to be able to have sex, or how am I even going to approach the subject? How is that going to make me feel, my partner feel? What if I can't satisfy my partner? There's a lot of things that probably go through your mind. So I'll talk to the patients about masturbation and different things, and and I tell them, not that I'm promoting it, but it's normal, and I also will tell them that it is actually therapeutic in getting blood flow down to the the penis, and I tell the patients that most men will actually try to experiment individually before they even get intimate with their partner, because they don't want that to go into a disaster mode. So anyway, I just try to get the couple connected together intimately, mentally, emotionally, before we get into the act of sexual function. So then we get to that later. Once a patient has an idea of how these products work, then I'll tell them, experiment with how things are working, and then you can use it for your intimate moments. But then I talk about a lot of modification, how you need to modify and learn how to please one another in other ways while you're waiting for your erection to come back or develop, or that trial and error point where you're waiting to see how a vacuum pump works, or if penile injections are going to be successful. So it's a trial and error process, and it can take sometimes weeks or months for patients, couples to get accustomed to. And then I always have patients call me or email me or something if they're having difficulty. And I'll just tell them, you know, you're not on your own. Just because I've discharged you or you've left the class, don't feel that you're out there on your own. You're still our patient, you still have needs, you're going to still follow up. And every time patients come back and follow up at 4 months after their surgery, they always have a session with me. I'm like their devoted sex therapist or something. All the doctors always bring him to my office. Here's Mr. So-and-so. He's here to talk to you about how he's doing with his pump and see if we can get him some new prescriptions. So, you know, they kind of send the patient to me, and I just feel fabulous how my role has all evolved into this, you know. So it's actually working, so. So I don't know if you guys have heard of penile rehabilitation. Has anybody heard of penile rehab? Okay, did your urologist, when you had treatment, did your urologist say you're going to be engaging in several products for your penile health soon after surgery? Okay, to some degree, maybe the Ottawa guys? Okay, offered, okay. Well, what is widely practiced? Without prompt penile rehabilitation using combination therapy, it is believed that patients are most at risk of developing fibrosis or collagen development, leading to irreversible scar tissue within the muscle of the penis within a short time after surgery or treatment. And that short time frame is felt to be about 4 months. So we really, you know, if patients say, I'm not quite there yet, I'm not ready to go down that road, I'll let them linger over it a little bit, but then not too long. And then I'm saying, come back, come and see me. I won't let them just run off scared. Because I pull them in and I show them it's not as difficult as you think. Collagen, fibrosis, the muscle of the penis has been impacted, and that's because the nerves have fallen asleep. I tell the patients, if you had a nerve sparing procedure, you're probably going to be somewhat okay. It may not be perfect, but you're probably going to be just fine. But we need to rehabilitate to wake the nerves up, because I tell patients it's going to be 1 to 2 years before you see any functional erections return. And in our hands, and I don't know what the rest of the country is, but usually the incontinence, that recovers quite quickly in comparison to the erectile dysfunction. So what we initiate immediately, and when I say immediately, I mean as soon as I get that suprapubic catheter out, we're getting patients on these treatments. So I give them prescriptions for either Viagra or Cialis. I tend to stick with Cialis as long as the patient doesn't have any adverse effect with it. It lasts for 24 hours on the daily dose, the 5 milligram daily, or even 2.5 daily. What that does by taking the drugs is it helps the nerves. If you take them at bedtime, it helps the nerves get stimulated with a little chemical reaction that helps blood flow get to the penis. Men have typically 3 to 5 erections at night when they sleep. But since your prostate surgery or treatment, that's minimally happening right now. So we need to rehabilitate and get blood flow back to those nerves to help them eventually in the next year or so. Vacuum erection devices, during our class, we will show and demonstrate a vacuum erection device, which I'll talk about on the next slide. And then there's Muse. I've got some placebos. I'm going to show you guys what Muse is. We give patients options of using something called Muse. And then we talk about the dreaded shot. Did you guys hear about penile injections? The dreaded shot. You thought it was some big harpoon beetle coming at you? It's not that big. So the oral medications, they are given a choice to start low daily dose medications such as Cialis 5 milligrams or taking 20 milligrams of Cialis 2 to 3 times a week. I tell them don't take the 20 milligrams Cialis every single day because it's overkill and you're going to get into toxic problems with too much of that medication in your body. But I give them the options. And a lot of this comes down to what they can afford and what your individual insurance plan will cover, and also what side effects you experience. Alternatively, if they had a bad experience with Cialis, I'll just say Viagra is one of the first on the market. It actually is very good too. The timing and how you take Viagra is very different, however. If you're going to take Viagra for sexual function, I tell the patient 1 hour prior to intimacy is when you need to take Viagra, and on an empty stomach. Oh, I didn't know that. Maybe that's why it wasn't working, patients will say. So it's a specific way that you need to take that medication. I do like Cialis 20 because it is known as the weekender. You can take it on a Friday, and it's good through Sunday morning. So it allows for a little bit more spontaneous of sexual function. It's not so much time, like, okay, honey, hour's up, let's get busy. So, you know, and that's how it is, right?